and say, okay, we know what Medicare reimburses for these drugs. So what should the reimbursement model look like for something that has 3 times the effect? Okay, so that's another angle. So now you're triangulating on the pricing, saying, if I look at it from an employer standpoint, I come up with the pricing model X. If I look at it as a health A1C reducing agent, like a drug, I come at it as Y. And then you look at it, it's amazing, and it's not just the US that has this employer thing. So I'll give you an example in India that's happening. It's unprecedented what's happening there in a number of different ways. But you have a lot of foreign companies who are providing the foreign benefits. So they're providing health insurance to their employees, and now all the Indian companies are like, oh, we got to provide these benefits, otherwise we have mass people leaving because they have better benefits packages working for a foreign national company. And so what they're doing is they're also now providing these benefits. And so what you're seeing is it's really a cocktail. And I think it's too early to tell is the honest truth, because I think you have to have a couple of instances where how is it valued by an employer, how is it valued by a disease management company, a hospital system. But I think that's the mentality going forward. It's not going to be a one-size-fits-all.
But isn't that why our system has to become more consumerized? Because that's a great example, right? So if you're looking at it from the healthcare provider or the employer, then they're going to be willing to pay these very high prices and continue to drive these huge costs in the healthcare system. Whereas if it was on the shoulders of the consumer, basically they'd be saying, well, I'm not buying this unless it's $19.99 or lower, essentially is what the research is all saying, right? So, McKinsey did a study saying, I'll pay up to $19 a month to have an effective mHealth solution for me. So then all of a sudden you're looking going, wow, there's a big gap there between those different viewpoints, and it's amazing. So if it's all driven from the one end of employers in the healthcare system, it's all going to continue, the prices are going to be much higher than if it's driven from the consumer side.
So it sounds like, I think just in terms of wrapping up the who pays discussion, I wonder if you'd agree then, is there anything unique about the question when applied to mobile health, or is it just like the way healthcare works in general in the US? I mean, it's just the regular way we pay for healthcare, right? It sounds like there's nothing new here then. Or is there something different about mobile health?
Well, we haven't talked much about public payers, about Medicare, and for that matter, private insurance. And that is one of the obstacles, because people are so accustomed to having somebody else pay for their health care, right? So there's a knee-jerk reaction there. The problem with getting a public payer like Medicare to pay is you have to do 2 things, basically. Number one, you have to address something that they're responsible for paying for. And that sounds intuitive, but everyone assumes that if it's health-related, then Medicare must pay for it, right? Well, eating fruits and vegetables makes you live longer. Try submitting your grocery bill to Medicare. They probably won't pay for it. There are an awful lot of things that advance your health that they're not going to go anywhere near. They've got enough to cover just with what the statute says they have to cover. So then the second thing is, if you're in a covered benefit, you have to prove that your technology really moves the needle, and that's what we're talking about here. So you have to have enough data in order to demonstrate that. Well, you get into a chicken and egg thing. I get all sorts of entrepreneurs coming to me and saying, this thing's going to be great, it's really going to work, and by the way, would you arrange to have Medicare pay for it, now? And it doesn't work that way. You really got to get up and running, demonstrate that the technology works in an evidence-based way. And then, if you're addressing a covered benefit, then go to the payers and get them to pay.
I will say one thing, though, and David raises a good point, and that is, this is a classic example of pricing in scope. You have 2 options. One is you try to harmonize the price, and you say it's a consumer thing. The other option is you actually have varying levels of scope. So maybe you have and who knows how this is going to play out, but one possible way this plays out is you have a simpler application that's there to support, say, general wellness and healthy eating and things like that, and you price it the way you price it. But then if you're actually going to move and you look at the different rungs of patients who suffer different acuities of either one disease or multiple chronic conditions, now you're starting to talk about a more integrated, larger solution that may come with it's a higher value proposition. It's therefore meaningful to price it higher. And so I think one possible answer is you actually change the scope. Yeah. And you change the scope based on what these different rungs are, and that's another way out of it.
Great. I think this is a good time to switch gears into the regulatory discussion. I know we're going to have plenty of questions at the end from the audience, and I'm sure business models will come up. So I was wondering, Bradley, if you could kind of give us an overview of what's new with the FDA. Are they looking at mobile health in a different way? Or could you say the same things right now are being done and it's being considered the same way as it was 12 months ago?
Well, when this panel came up, I asked Brian if he would be willing to move CMS CMS is the Medicare agency, CES 1 week, because on Monday I've got a meeting with all the senior leadership at the Device Center to ask them sort of a variation on that question. The short answer is that things are getting through the agency. We do see technology periodically approved. The bigger question for me is still the scope question of what needs to go through that process. And on Monday, our plan is to raise 3 topics with the agency. The first topic is intended use. What determines whether or not a product gets regulated by FDA is what you intend the product to be used for. And I'll give you an example. You might have a weight scale, a simple weight scale. And if you sell it for just everyday weight management, it's not regulated by FDA. If you sell it as part of an obesity program where it's being used to treat people who have obesity, obesity is technically a disease. You're now into a disease realm, and FDA regulates it. Exact same physical product goes from regulated to unregulated depending entirely on what you say. So one of the things we're going to talk to FDA about is whether there's some way to clarify which types of claims might lead to FDA regulation and which ones they'll treat as outside their scope. The second thing we're going to raise with them on Monday is their so-called accessory rule. And this rule has, for 30 years, basically said, if you plug something into a medical device and connect it to the device, it's regulated in the same way as the device is. Well, geez, everything we're talking about is connected to everything else. One way, it doesn't mean wired. Wireless is a connection just as much as wired. And so that implicates all sorts of things. All of a sudden, AT&T has to think, well, you know, is the basic tube that we sell for the data, it's connected ultimately to this device. Does it get regulated the same way? One of the other questions is the level of regulation. And this is for some of the medical technology companies. They make devices that are so-called Class 3 medical devices, the highest level of regulation, like a pacemaker, something that's truly your life depends on it. They want to send the signal through the cell phone, right? And the question is, well, what happens to the cell phone when they do that? Does it get regulated, not only regulated by FDA, but to the same level as the pacemaker, which is a place you do not want to be if you don't have to be? So we're going to try and talk with them, start the discussion around that topic. The third one then is software apps. And we're going to talk specifically about what functionality of software is going to, in their view, trigger FDA jurisdiction and which ones won't. And we'll go in and present a range of different functionality that is typical in the mHealth space and begin a dialogue with them about that. The overall plan is to have this meeting, begin that discussion, take about 3 months to write a proposal to FDA regarding how they should regulate this space and submit it to the FDA for formal consideration and hopefully adoption in some fashion. So the agency has basically said publicly, look, we are so busy on so many different things, and they truly are, that we can't develop policy in all these areas, but if you guys are willing to do it, we'd be willing to look at it. A key element of that is we are trying to reach out to all the different stakeholders. So we're trying to talk to patient groups and provider groups, and as well as manufacturers and so forth. So we really want to try and get as many perspectives as possible. But that's the game plan, and so by maybe spring, FDA would have something concrete that they could move on.
Great. I know Anand, WellDoc just went through the process, just wrapped up the process last year. I was wondering if you had any comments to add in terms of maybe during the course of those 2 years, did you notice any change at the FDA, or any thoughts to add to Bradley's before we move into audience questions?